Good afternoon, everyone. Welcome to Medical Grand Rounds. It's 12 noon, so we'll get started as people are coming onto the into the conference. As mentioned, those of you who are here, you're welcome to join us in D02-1312 here at the Glen. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please leave your questions till the end of the presentation. I ask that you please enter them in the chat. And as well, please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you were present today. And finally, I'd like to invite our Chief of the Division of Geriatric, Dr. Zé, who will introduce our speaker today. Thank you very much.
Good afternoon, everyone. So it is my pleasure to introduce you our today's conference speaker, Dr. Sundeep Khosla, who is Dr. Francis Choker and Nathan Landow, research professor, and also Mayo Foundation distinguished investigator, and from Mayo Clinic College of Medicine and Science. Dr. Khosla is an endocrinologist with who studies age-related bone loss through his osteoporosis and bone biology laboratory. Dr. Khosla examines fundamental aging mechanisms in bone, especially cellular senescence leads to increased skeletal fragility. Dr. Khosla also studies how the aging skeleton interacts with other tissues, including muscle, fat, and brain tissue. Dr. Khosla's lab has developed several genetic models for the clearance of senescent cells globally and in a tissue-specific manner. Dr. Khosla work has the potential to significantly impact how people with osteoporosis are diagnosed and treated. It defines the pathways that leads to bone loss with aging. These pathways may identify new molecular targets for medicines to reverse osteoporosis. Additionally, his studies on fracture healing may lead to new approaches to prevent fracture nonunions. So his title of his presentation is Targeting Cellular Senescence to Treat Osteoporosis. Dr. Khosla, please come up to the podium. Thank you.
So, thank you, Dr. Moret, for the kind introduction. And it's a real pleasure to be here in Montreal and interact with so many of my colleagues last night in geriatrics and other areas. So these are my financial disclosures, which are not relevant to the presentation here. So what I want to do is kind of start and end on a clinical note, and then review some of the biology and the translational work that we've done, and really start with current gaps in osteoporosis treatment, provide a brief overview of senescence, and then its role in age-related bone loss and frailty, early attempts at clinical translation, and then future directions. So in terms of osteoporosis, we really have made remarkable progress over the past 25 years. So, when I joined Mayo back in 1988, when we would go to the osteoporosis clinic, we would offer estrogen to women and mainly calcium and vitamin D to men. And then you fast forward, we now have estrogen is not as used as much, nor is raloxifene, but we have 4 bisphosphonates, we have teriparatide, abaloparatide, denosumab, and romosozumab in our therapeutic armamentarium. And in fact, actually, the development and discovery of these drugs, as I point out when I talk to my colleagues in the public, is that, a lot of these have been driven from fundamental advances in bone biology, whether it's through understanding new pathways, like it was with the rank ligand OPG system, or it's through rare bone diseases like in sclerostosis that led to the discovery of romosozumab. What then is the case for new approaches to treat osteoporosis? And I think there still is. So it's a huge public health problem. it's not well appreciated that the number of women who experience a fracture in 1 year actually exceeds the combined number of women who will experience incident breast cancer, MI, or stroke across all age groups. So fractures with substantial morbidity, and in the case of hip fractures, mortality is clearly a huge problem. And then there are important gaps in the therapeutic arsenal. First, especially with the bisphosphonates, the fear of rare side effects, including osteonecrosis of the jaw and atypical femur fractures, really has led many primary care and other physicians to not prescribe these drugs or patients not to take them. So there's undertreatment of people who really need these drugs. Then there's some kind of clinical and biological issues. So the efficacy of bisphosphonates beyond 5 years is still unclear. We don't really have a perfect long-term anti-resorptive drug. And something that will become relevant to the data that I'll show you, that even with the anabolic drugs, the most potent of them being romosozumab, they all stimulate bone formation for a few months, and then the formation comes back down to baseline. So that has to do with the underlying bone biology, and we don't quite understand why the skeleton resists continued bone formation, why there's this transient increase, then it comes back down. It's seen with teriparatide, abaloparatide, and also with Romo. And as I'll show you, it becomes relevant to some of the senolytic approaches that I'll talk about. But this is a big underlying question in bone biology, probably one of the major unsolved mysteries in bone, is why can't we cure osteoporosis? We can't cure it because we can't continue to indefinitely stimulate bone formation. But I think beyond that, there's a fundamental kind of broader problem with current treatments for osteoporosis and other chronic diseases. So as the geriatricians in the audience know, the current treatment strategies are really disease specific. So a patient, in the 70s might take a statin and an antihypertensive for cardiovascular risk reduction. They might take an antihyperglycemic for diabetes, a bisphosphonate for osteoporosis, and so forth. And inevitably, this leads to polypharmacy. So almost 70% of older adults take 5 or more medications. And this obviously leads to an increased risk of side effects, adverse drug interactions, and non-compliance. And then more specific to osteoporosis, the busy primary care physician is often dealing with what are perceived as more pressing issues like the blood pressure of 170 or the blood sugar of 210, and the T-score of minus 2.7 kind of drifts down the list until the patient actually presents with a hip fracture, when that hip fracture likely could have been prevented if treatment had been started a number of years ago. So getting osteoporosis on that critical list is sort of an added burden that this specific disease, which is nonetheless important, has to struggle with. So, both in my clinical and my research thinking up until about the early 2000s, I would, as an endocrinologist and bone biologist, and I would think about osteoporosis in isolation, like all these other diseases. And then around that time, we formed the Kogat Center on Aging, and I moved my lab actually from the endocrine research unit and to the aging center, and really began to kind of reformulate my whole research enterprise, which had been focused on estrogen action on bone, to actually learning about gerontology and geriatrics and kind of going in a new direction. And that's where I really, along with my geriatrician colleagues and gerontology colleagues, began to think about osteoporosis not in isolation, but in the context of all of these other multiple diseases of aging that it travels with. And this kind of fundamental understanding has now evolved in the field to what the geriatricians are very familiar with, which is the geroscience hypothesis. And this argues that if you manipulate fundamental aging mechanisms, this will delay in parallel the appearance or severity of multiple chronic diseases, because these diseases share the same underlying risk factor, which is aging. So rather than trying to fight each disease on its own, could we actually target common aging mechanisms that underlie all of those diseases and have a much broader societal impact? So that's really the hope. So in that context, senescence becomes important. I refer you to this kind of nice perspective published a couple of years ago. It's actually an update of a previous perspective where they identify sort of the hallmarks of aging. And these have evolved from 9 to, I believe there's now 12. And they're all highly interrelated. You can recognize some of these, obviously genomic instability, telomere attrition. There's kind of a whole list. I think the important point is that while they're identified as separate hallmarks, they're highly interconnected. So it's known, for example, that mitochondrial dysfunction leads to a number of abnormalities, including cellular senescence. I can go through the whole list, and they're all interconnected. Be that as it may, it's important in terms of thinking about aging and maybe studying specific pathways and then seeing how they interact with others. And my lab has been focused on cellular senescence for over a decade. So what is senescence? It's not a new concept. It was actually, as you might recall, described by Dr. Hayflick back in the 60s. It's a cell fate that involves irreversible replicative arrest, activation of tumor suppressors, chromatin changes, resistance to apoptosis, and an increase in protein synthesis. And it was originally described for mammalian mesenchymal cells by Dr. Hayflick in culture. And what he found is that as you continue to culture mammalian fibroblasts here, that eventually they stopped proliferating. They didn't die, but they reached a stage that he called senescence. Now, since the 60s, our understanding of senescence has obviously improved dramatically. We now know that it occurs not just in vitro, but in vivo, that it occurs not just in dividing cells, but also in quiescent terminally differentiated cells like neurons, cardiomyocytes, in my case, osteocytes. So the mechanisms of senescence are better understood, and the cell types and the situations in which it is present is much better understood. So the hypothesis is that with aging, you accumulate a minority of these senescent cells, maybe 10 to 15% in any given tissue, but the increased protein synthesis that I mentioned really refers to the senescence-associated secretory phenotype, or SASP, which is a highly pro-inflammatory secretotype. It's a sterile inflammation, essentially. So the 10 to 15% senescent cells amplify their signal by virtue of the SASP. And the hypothesis is that if you target these senescent cells, they would have a rejuvenating effect on aged tissues. Now, as I mentioned, the cellular and molecular mechanisms driving senescence are increasingly better understood. So it's now known that a host of cellular stresses, primary among them are DNA damage, but oncogenic mutations, reactive metabolites, IGF, for example, telomere erosion. You can see all of these. They trigger activation of two key genes, P16 and P21. I mean, you could argue that one of these two is necessary but not sufficient to initiate senescence. I know some would argue that you can have senescence without any of these, but I don't know any good examples of that. So I would argue that you need at least one of these. Now, the other feature of a senescent cell is the SCAPs, or the senescent cell anti-apoptotic pathways. So there's upregulation of a number of anti-apoptotic pathways. You can see the BCL2 family here, and this will become important in a moment. There's also then a DNA damage response, which leads to mitochondrial dysfunction and the secretion of pro-inflammatory cytokines, and eventually the SASP, which causes tissue dysfunction. Now, a couple of approaches have been taken to try to target senescent cells. One is the senolytics, which were designed to try to target these SCAPs. So the idea, kind of like antibiotics, is that if these pathways are highly upregulated in a senescent cell, and the senescent cell is very reliant on these pathways for survival, well, if you could target those pathways, you could maybe selectively kill senescent cells. And the other point is that because senescent cells take weeks or months to accumulate, these senolytics don't need to be there all the time. It's kind of a hit and run mechanism. You can give them, kill the senescent cells with minimal harm to normal tissues, and then wait a few weeks or a month before you give the next dose. And that's actually what we've used in our mouse and in our clinical studies. The other approach is the xenomorphic approach. So here, these drugs don't kill the senescent cell, but they inhibit the secretion of the SASP. And the prototypic xenomorphics are actually already in clinical use in the form of JAK inhibitors. There's a lot of data now showing that the JAK-STAT inhibitors actually, without killing senescent cells, inhibit the secretion of the SASP and may well have beneficial effects in terms of their aging phenotypes. So let me turn now specifically to bone. We showed a number of years ago and then updated some of this. If we look at mice, so we used here P16, which I told you was one of the critical genes for senescence. So this is an initial marker that we use, upregulation of P16 for senescence. So this is an osteocyte-enriched bones from either female or male mice. And you can see there's not much happening up until about the age of 18 months. And then there's a marked increase in P16 message. Now there's, different kind of conversions, but I would say 18 months in mice is roughly probably 65 to 70 years in humans. And I'll come back to this because we really don't see in humans much by way of senescent cell accumulation, at least in our hands, prior to age 70. So it really is a aging phenomenon. There are more specific assays for senescence, specifically these telomere-associated foci, which measure one of the hallmarks of senescence, which is irreversible telomeric DNA damage. So when the telomeres get damaged, the cell can't replicate, so their growth arrested. So here, a telomeric probe is used along with a probe for DNA damage, and where they co-localize is a telomere-associated foci. And you can see in mice, in bone, they go from very low to about 10% of the osteocytes by this criteria, which I would consider a gold standard, have become senescent. Now, we've looked in humans. These are tiny needle bone biopsies that we can get. And you can see these bone biopsies, which are admittedly heterogeneous. There's bone and then bone marrow, immune cells. You can see an upregulation of both P16 and P21 in humans, and selective upregulation of a number of SASP factors also in humans. Now, this is not a comprehensive survey of SASP factors, and there are more that have become validated. Now, the other thing that became important is to prove causality, selectively clearing senescent cells. And this is a transgenic mouse model that my colleagues at Mayo developed and we had access to. So it's a very clever model. It uses a P16 promoter, which I just told you P16 gets upregulated in senescent cells. It drives this fusion protein, which by itself localizes to the membrane but is inactive. But when you give the synthetic drug, which is not known to have any effects on any other tissue, all this does is dimerize the FK binding protein and activates the caspase. So basically, in this model, you can time when you want to clear senescent cells. So you can age the mouse, for example, to 20 months and then start treating with AP to clear the senescent cells, because you don't want to be clearing senescent cells in growth and development, because they're known to play a role there. So the one shortfall of this, which is the second model that I'll come back to, is that this clears senescent cells everywhere. We've now developed second-generation models that are cell-specific, so we can actually decide when and which specific senescent cells we want to clear. And this just shows in an old mouse, this is an epididymal fat pad stained for SA beta gal, which is a reasonable marker for senescence. Whereas in a treated mouse, you can see the SA beta gal cells have been cleared. So we did this in mice. We took 20-month-old mice and treated them twice a week for 4 months with AP20187. And you can see in the spine, in the treated mice, they had better spine parameters consistent with a attenuation or prevention of age-related bone loss. We saw the same thing at the femur, an increase in cortical thickness and the strength of the femur. And histologically, we saw a reduction in bone resorption with a reduction in osteoclast numbers and an increase in bone formation. So both good effects for bone, less bone breakdown and more bone formation. Now, obviously, you can't use these drugs, this transgenic approach in humans. So my colleague, Jim Kirkland, was amongst the first to develop what I would call the first generation senolytic drugs. So in this paper, they described the transcriptome analysis they performed to identify the key pro-survival networks that I mentioned. Then they didn't do high throughput drug screening. They actually used in silico drug screening. They used a bioinformatic approach to match known compounds that inhibited these pro-survival pathways. and they actually identified dasatinib, which is a clinically used tyrosine kinase inhibitor, and quercetin, which is a flavonoid, which kill these cells. And then when they gave these compounds to progeroid mice, it extended health span in these mice. So we took the same approach. We took aged 20-month-old mice and gave them vehicle or D plus Q. The important point here is we only gave the D plus Q once a month, kind of going back to this hit and run approach. It's not continuous exposure. And I won't go through the details, but reassuringly, the skeletal phenotype was identical to what we saw with the genetic approach in the Incotac mice. So whether you used a genetic approach or a pharmacologic approach, you got the same skeletal consequences, including this reduction in bone resorption and increase in bone formation. And we also tried it with the JAK inhibitor. So this was JAK inhibitor treatment. Now, the difference is the JAK inhibitor needs to be given continuously because it's not killing the senescent cells, it's suppressing the SASP. But again, the skeletal phenotype is pretty much the same to using a senolytic approach. So for this part, then in old mice, 2 to 4 months of treatment with either senolytics or xenomorphics improved bone mass, microarchitecture, and bone strength. This was due to a suppression of bone resorption with an increase in bone formation. And then we did a number of in vitro studies trying to understand the mechanisms by which osteoclastogenesis was improved. But importantly, we showed that in young mice, we didn't see these effects. So you required a high senescent cell burden to actually see a demonstrable effect. But what about frailty and lifespan? So in this study, what we did was we irradiated cells and made them senescent and put them into the peritoneal cavity of young mice. So what would happen if we put senescent cells into young mice and into the peritoneal cavity? These studies were done in collaboration with the Kirkland lab. And these cells were labeled with a luminescent reporter. So you can see these cells remained in the peritoneal cavity. And despite that, in 6-month-old mice, you can see as little as about 1 million cells started to have effects on frailty, which is what you see here. So if you look at grip strength, for example, by the time you get to 500,000 or 1 million cells implanted, which is a small fraction of the total number of cells in the mouse. So clearly implanting senescent cells in the peritoneal cavity of young mice had a systemic effect in terms of inducing frailty in the young mice. And it actually induced senescence markers distally. So this is in the quadriceps muscle where there's an increase in IL-6, TNF-alpha, P21, and also in P16. And we actually replicated these findings also in other models. When we put these same cells in the peritoneal cavity, we can actually see induction of osteocyte senescence in cells embedded deep in bone. So we did the same thing in old mice, which was to treat with DQ. So this was 20-month-old mice treated, again, here it was twice a month with vehicle or DQ. And again, DQ treatment, which is a senolytic approach, improved measures of frailty in the old mice. And interestingly, also improved survival. So post-treatment, the vehicle-treated mice survived a median of 140 days, whereas the DQ mice survived 191 days. So in terms of frailty, which is obviously important in the context of fracture, frailty is increased and lifespan is reduced by increased senescent cell burden. Clearing senescent cell burden reduced both frailty and increased lifespan. And there's a feed-forward loop where senescent cells induce senescent cells. This was known to be a paracrine effect, but it also likely is a systemic effect, probably from the secretion of the SASP. So we've done a lot of other things kind of trying to understand the biology of senescent cells in bone, but I want to turn now to at least beginning to translate this into humans. So over the years, we developed this working model where if a senolytic targets a senescent cell, there's a reduction in bone resorption and an increase in bone formation. And so these, as I mentioned, are beneficial effects. Now here I want to come back to sclerostin and romosozumab. So sclerostin is well known to the bone people because it's produced by osteocytes and it's a potent inhibitor of Wnt signaling. So when you come in and neutralize sclerostin, which is done clinically with romosozumab, which inhibits sclerostin, what you see is activation of Wnt signaling and an acute increase in bone formation and an acute reduction in bone resorption. This simultaneous increase in formation and reduction in formation is arguably pathognomonic of the effects of the activation of Wnt signaling in bone. I don't know of any other therapeutic agent in bone that gives you this particular skeletal phenotype. So it struck us that with our senolytic approaches, this is what we were seeing. And with activation of Wnt signaling, this is what you see. Could there be, at least in part, a common mechanism between senolysis and sclerostin inhibition? Well, we looked at this in vitro. So these are mouse osteocytes that we induced to become senescent with peroxide. And you can see in these early osteocytes, sclerostin message is not expressed, nor is the DKK, which is another Wnt inhibitor. But when these cells are made senescent, there's a marked upregulation of both sclerostin and DKK1. When we looked in vivo in our mice, so this is in our genetic model where we clear senescent cells in bone, we also see a reduction in the SOST and in the DKK1 message. As I mentioned, we've developed more specific models. I won't go into the details, but here, instead of clearing all senescent cells, we only cleared senescent osteocytes. And we saw the same thing, a reduction in the sclerostin message. And then when we treat with DQ, here's in wild-type mice, we see a reduction in bone in the sclerostin and the DKK1 message. So whether we use wild-type mice or genetic mice, whether we use a genetic approach or a pharmacologic approach, it's remarkably consistent that we see a reduction in the SOST message in vitro and in vivo. And that really prompted us to think that, well, maybe senolysis was somehow linked to Wnt signaling in bone. So with that as background, I'll describe our clinical trial that was published last year. So this was the first randomized control trial, actually, of any senolytic in humans, testing whether this could be beneficial and could produce a beneficial biological signal. This was not an osteoporosis treatment trial. It was really to look for biology. It was to understand whether if we cleared senescent cells with DQ, could we find a signal for efficacy of any sort? And as I mentioned, we chose CTX, which is a bone resorption marker, and P1NP, a bone formation marker, as our primary and secondary endpoints. As I tried to describe, there's no data in humans. We could have just as well chosen P1NP as our primary endpoint and CTX as our secondary endpoint. It was just arbitrary which one we chose. And that's always the case in these first-in-human trials. You don't actually know how the compounds are going to behave in humans based on the mouse data. But importantly, we also pre-specified that women with a high basal senescent cell burden would be more likely to respond to a senolytic intervention. So to assess senescent cell burden, we used P16 expression in T cells as a biomarker. And this is based on the fact that, as I told you, P16 is a key mediator of cellular senescence. There had been previous studies from the Sharpless laboratory. Dr. Sharpless was at NCI and then subsequently was at UNC and then subsequently became director of the NCI. His lab had shown that T cells P16 message levels increase with age, and of course T cells are easily accessible. And he showed that T cell P16 message also increased with tobacco use, physical inactivity, following chemotherapy, and they were associated with plasma IL-6 levels. So they seem to reflect activities or interventions that would correlate with senescent cell burden. And then in our study, as described in more detail in our paper, we actually used a modification of the original Sharpless assay that demonstrated in our hands a stronger correlation with age in women over 60. So this was a 5-month or 20-week randomized controlled trial. It wasn't double-blinded because it was done on an R21 grant from NIA, and we could not afford to over-encapsulate all the pills. It was just cost inhibitive. So it was untreated or treated, but both groups underwent, so it was open label, but both groups underwent the same study visits and assessment. And it was a reasonably sized study with 30 participants per group. Now, we actually selected older women with a senescent cell burden based on the T cell assay that was above the 95th percentile of young control women. So we actually developed some normative data in younger women, and we wanted to select older women that had a high senescent cell burden. And yet, as I'll come back to show you, even that might not have been high enough. These were otherwise healthy women. They had not been on any bone active drugs and so forth, and they were all vitamin D sufficient. So the control got no drugs. The D plus Q got dasatinib, 100 milligrams per day for 2 consecutive days. And they got quercetin, 1,000 milligrams a day for 3 consecutive days. And this schedule was repeated every 28 days over 20 weeks. So there were 5 dosing sessions, and they all took calcium and vitamin D. This just shows the overall design. The dosing was kind of at the beginning of each cycle, and then it was a 5-month study. So in terms of the results, if we looked at the percent change in CTX at 20 weeks minus baseline, we didn't really see any change. But when we looked at P1NP, particularly at the earlier time points, we started to see a signal where it was different in the DQ, not by much, but it was different in the DQ versus the control women. So this seemed promising to us, and something that we probed in depth. So yes, the primary outcome was not achieved. Secondary outcome, as I said, did show a biological signal, but what would that mean? So this is where I think in these early phase trials, you really have to understand to try to set up the next set. So we undertook a number of exploratory mechanistic analyses. So our first hypothesis was that the underlying senescent cell burden dictates the clinical response to senolytics. And the second, as I've just shown you, was that senolytics may be having their skeletal effects, at least in part, through inhibition of sclerostin. So what about the first hypothesis? This shows the distribution of the T cell P16 message levels as a function of age in our women. And in our initial analysis, the women that were in the highest tertile compared to the women in the lower 2 tertiles seemed to be behaving differently. And when we looked into this further, that was indeed the case. So here's the time course of changes in the bone formation marker in the women in the highest tertile for P16 T cell levels. And here you now start to see a reasonably robust P1NP response, almost 40% different from control. But if you look at the T1, T2 group, the lower 2 tertiles, there's absolutely nothing. You see the same thing with CTX. In the highest tertile, a significant reduction in CTX that returns to baseline, but no change in the T1, T2 group. Now, this time course is something that I'll come back to. Here's a modest anabolic response that wanes by 20 weeks. Look at bone density, actually a positive signal for radius bone density, which improved significantly in the women in the highest tertile, but no significant change in the women in the lower 2 tertiles. So what about the sclerostin idea? So here are the data from the pivotal romosozumab trial. And you can see, look at P1NP in these women. It actually goes up dramatically in the first week, peaks at about week 4, and then comes back down to baseline. So yes, sclerostin is a potent anabolic, but it's really only an anabolic for the first few weeks. And look at resorption, it acutely goes down and then comes back towards baseline, and then there's a later reduction. So here I actually replotted the Romo data in the time scale that we had in our trial, and you can see with Romo, this dramatic increase in week 1 to week 4, and then it comes back towards baseline. Very similar qualitatively, although it was smaller in magnitude with DQ, very similar profile with this acute increase that comes back down. Why, again, formation wanes with both drugs that I think are acting through the inhibition of sclerostin is unclear. And that's a bone biology question that remains to be answered. Here's the resorption side with Romo. You see this acute decrease, very similar profile with DQ. So I think this is perhaps an example of where a specific SASP factor, because we believe that, in fact, sclerostin is a SASP factor, not just in bone, but across tissues. If it's of particular importance to a given tissue, in this case bone, the clinical phenotype may actually be driven largely by inhibition of that factor. Now, there may be other factors that are also being influenced by senolytics that remain to be kind of defined. So based on our data, about 30% of all women above 70 would be in that T3 group that I described and might have a beneficial skeletal response to DQ. And in fact, we're now in the process of putting together a multi-site trial that is actually going to select women only in this group to really test this rigorously, because we don't think if you're in the lower two tertiles, you're going to have a good skeletal response, at least based on the assays that we have. But are there other means, easier ways to identify these women that might have the T3, the T cell P16 assay is a pretty cumbersome assay. You have to isolate the T cells. It's a qPCR or TACMAN-based assay. Can we do it through circulating measures? So here we actually went back to our original, where at baseline we had measured a panel of 32 SASP factors. And interestingly, this is unrelated, when we measured those factors, we didn't have bone in mind. But it turns out that sclerostin was the most significantly different in the women in the T3 versus the T1, T2 group. So it really is a legitimate SASP factor, and it's clearly different. Now, there were 5 others that were clearly different or borderline different. So we developed a very simple SASP score, which was simply the geometric mean of these 6 SASP factors, and asked, can we use the SASP score instead of the T cell assay, which is cumbersome? And the answer is yes. So here's the P1NP response if the women were in the highest tertile for the P16 assay, and here's the profile if they're in the highest tertile for the SASP score. It actually performs as well or even better than the T cell assay. Now, there was a small subset of women that were high for both. So they were high for the P16 T3 assay, and they were also high in the SASP score. And those are women that I would call the super responders. So they actually had almost a 60% increase relative to control in P1NP, kind of getting close to the range that you might actually see with romosozumab. So what this shows is that if you start with all women, you see just a hint of a biological signal. But if you then select out the women that are high either for the T cell assay or their SASP score, you now start to see a more robust signal. And then if you select out the ones that are highest for both, you see a clear signal. Now, obviously, these are exploratory analyses. They don't prove this. And that's the reason we're now in the process of planning this multi-site study where, for ease, we're going to select women based on being in the highest tertile for the SASP score, randomize them to placebo or DQ, and then look not just at bone, but also frailty, cardiovascular function. Because now that we have a biological signal and we know how to classify these women, I think the next logical step is a multi-organ trial like that. And that's why I really argued to my colleagues that you need to take a very kind of slow but systematic approach to this issue and not just try a whole bunch of senolytics to see what works. Because, aging is heterogeneous. You're going to have to find the right kind of patients that will respond to a particular intervention. Because it's possible that those 70% of women without the high SASP score, there are other aging mechanisms more important than senescence that are operative in those women. And they're not going to respond to a senolytic. Maybe they'll respond better to, other compounds targeting different aging pathways from senescence. So I think we need to kind of step back and think about the heterogeneity of aging and maybe try to classify participants more rigorously. But I think this also says that it's clear that, in my mind at least, that this increasing senescent cell burden really drives the clinical bone formation response. And I think that's, implicitly or intuitively makes sense. So the SASP score may be able to work, and it supports the idea that the skeletal response to DQ is really driven by the underlying senescent cell burden. So to summarize then, in terms of the trial, we did see a biological signal with P1NP, but I think more important than the biological signal was where it led us in terms of trying to understand where to go next. And I think this has implications for the use of senolytics and the design of future studies across tissues. And I think the sclerostin story, I'm partial because I'm so interested in it from the skeletal perspective. But it suggests that the inhibition of sclerostin may be important not just for bone, but perhaps across other tissues. And maybe that's not been explored in detail. This was a very suggestive paper where they showed that in mice, largely with some human data, that osteocyte-derived sclerostin actually impaired cognitive function during aging in mice. Now, whether it's truly osteocyte-derived, or it's possible, we have other data, for example, that when human endothelial cells become senescent, they start to produce sclerostin. So could it be local production of sclerostin by endothelial cells in the brain that's actually causing this and, potentially affecting cognition? So I think it opens up other possibilities. And that's why I think trying to understand kind of the underlying biology behind, these early clinical trials really is important. So what about future directions? So I think the kind of the idea that we have is that with aging, you get this accumulation in senescent cell burden that leads to death. I think we're really at the first generation senolytics. DQ, I think, is a first generation senolytic that probably requires a pretty high senescent cell burden for it to work. The hypothesis is that as we go to second or third generation senolytics, that maybe we can actually find efficacy at even lower levels of senescent cell burden rather than these very high levels that seem to be required, at least in the context of otherwise normal healthy aging, which is what our study participants were. And obviously more work to test that hypothesis. So I just want to end. So we published this paper about 7 years ago where we showed that in mice that targeting senescence prevented age-related bone loss. It took us 7 years, but it was particularly gratifying in the same journal to publish then the first human study on this. And as a translational scientist, I guess I tell my younger MD and MD PhD colleagues that, it's when you can do this, that's what gives you the most satisfaction. You can actually take a concept that you test in the lab in mice and actually go ahead and test it in humans, learn from the humans, go back to the mice, but also go to better human studies than the one you were able to do. And that iterative process, I think, is really, in my mind, the joy of science. So overall, what we hope is that as, senescent cell burden increases and leads to frailty, that hopefully we'll be able to intervene and certainly increase health span. And that, obviously, senescence is not going to be the only way to do this, but perhaps one important way. And I'd like to end with folks in my lab, collaborators in the Labrasser, Kirkland lab, and other collaborators at Mayo and elsewhere, and funding that we've received from NIA, NIAMS, and Mayo Foundation. Thank you.
Thank you. Absolutely fascinating, fascinating lecture, Dr. Thank you very much for joining us today. Are there any questions, Dr. Morin? Do you want to come up here so people can hear your question?
Yeah, thank you very much for a very interesting presentation. So I have two questions. The first one has to do with, is there a clinical phenotype of these women who seem to have the highest level of senescent cells, or do you just base your recruitment strategy on age alone? And my second question has to do with whether you can harness some of the data from the large romosozumab trials or, clinical registries where you might potentially be able to access either serum or whatever to try to see whether other biomarkers are affected in the way you were mentioning.
Yeah. Those are excellent questions. So the one phenotype was that they were all over 70. In our cohort, there wasn't a single woman under the age of 70 that was in that T3 group. So age, and then, that's kind of fits within mice. We don't really see the increase in bone until about age 18 to 20 months. So because these were exploratory analyses done after the study was completed, we have not gone back to the women to do frailty testing or do other testing. That's actually an interesting question. It may be worthwhile, to go back and do that. And that's something we, haven't really thought about as much. And then, but it's possible that they had more comorbidities or, because even above 70, there's heterogeneity. age alone isn't enough to identify these women. Even above 70, only a third of those women really fell into that category. Now, in terms of the Romo data, that's something I'm quite interested in doing. I don't think they did. First of all, a lot of those were younger women that were treated, so it would probably have to be in the older subgroup. And I don't think they did any frailty or cognitive testing, which is what would have been of interest, but they may have had biomarkers and those kinds of things that might be useful. And I mentioned this to some of the folks at Amgen, but so far, they haven't really, they've shown interest, but we haven't really actually done any measurements.
Thanks, Dr. Moret. The floor is yours.
Thank you very much for a very interesting lecture. I was wondering about any measurements, clinical measurements done on muscle function, mitochondria, etc. Is there any data available?
Yeah. So we have not done that in this trial. It's something that we plan to do in the follow-up trial that we hope, to actually pursue. The data that's available is a study that my colleague Nathan Lebrasser did in older individuals, and it was a exercise training regimen in older, I believe it was in older women. And what they were able to show is that with the exercise training, when they looked at the T cells and measured P16 and a few other SAS factors, that they did come down with exercise. We've seen the same thing actually in a sub-analysis from the calorie study with caloric restriction. So Nathan actually got fat biopsies from that study. And we did RNA sequencing on those fat biopsies and looked at this Mayo gene set that we developed as a marker for the SAS. And with calorie restriction, there was a significant reduction in Mayo. So I guess, while we're waiting for the senolytics, modest caloric restriction and exercise, which is probably what I would have said at the beginning of my talk, are probably the only two proven things that might reduce your senescent cell burden, but people don't necessarily, want to do that.
Thank you.
I'd like to go to some questions in the chat. There's a few questions here. There have been reports of different SAS proteins in different studies. Do you think there might be different SAS scores from different tissues, example, bone versus kidney versus heart? So we might need different markers for senescence in different tissues.
Yeah, that's an excellent question. The SAS can be very cell and tissue specific. I think, when we kind of looked at our SAS score, it was just looking at blood proteins in these women, not with any, bone outcomes that might reflect those SAS scores. So it's possible that, that combination of SAS score might be one of the ones that's reflective of a, overall high senescent cell burden. But whether that SAS score only predicts a skeletal response to DQ or a muscle response also, or a cognitive response, I think remains to be seen. And it's very possible that you may need, different types of SAS scores for different tissues. I think, that remains to be seen. So the best thing I think is to, collect the serum and plasma and measure panels of factors and try to see which ones work best in different settings and then test them further prospectively.
It's a question about potential risk of senolytics in cancer. Could you please comment on adverse events of QND?
Yeah, so our study was a fairly short-term study. It was a 5-month study, and overall the DQ were reasonably well tolerated. Some had some mild GI effects, but we are continuing to follow these people for up to 2 or 3 years. I think the cancer concern obviously is an issue because as you're referring to, the senescence was historically thought of as an anti-cancer mechanism. So the idea being a cell gets DNA damage, they either become cancerous, they die, or they trigger the senescence pathway and become senescent. So it was thought to be one way of preventing the cell from becoming cancerous. So that's going to remain a concern. I think arguing or mitigating that concern is the fact that the senolytics really are going to need to be given only intermittently. So by this very intermittent administration, you're actually not going to stop new cells from forming, senescent cells from forming. You're just modestly reducing their burden from maybe 15% down to 10%. So I think the goal in the aging kind of treatment or prevention is not elimination of senescent cells. It's a modest reduction in those cells, which has an amplified reduction in the SASP and better health outcomes, rather than reverting you to a youthful phenotype, which likely isn't feasible. But I think those questions will continue, and I think they need to be addressed. It's also important to note that senescent cells, once there is a cancer, actually promote cancer, because that SASP is so pro-inflammatory that it promotes tumor growth. And there's a lot of interest in the oncology community actually about, and chemotherapy also causes senescent cells to accumulate. So there's a lot of interest about using chemotherapy in combination with senolytics to actually clear the cancer of the senescent cells that have kind of a forward loop with the cancer cells. So the interaction with cancer is fairly complex, and I think continues to need to be worked out.
Okay, do you have any data on racial or ethnic differences in the markers of senescence?
That's a good question, and unfortunately we don't. We live in Rochester, Minnesota, where 99% of the population is Caucasian. So I think it's important to look across populations now. I know there's a geroscience network in the US, and Gustavo Duque here is leading a geroscience network in Canada. And I think it will take large consortium studies like that to actually look at these, senescence markers, whether it's the T cell assay or SAS proteins and so forth, because there may well be. And the accumulation of senescent cells may well have substantial racial or ethnic differences.
Okay. Do you think there could be polygenic risk scores that will allow you to find patients who might be responsive to treatment?
Yeah, that's the hope. That I think right now the two risk scores, would be age and a SASP score, but there may be genetic determinants that you might have SNPs in the P16 gene, or other markers that say, well, as you age, you're one of those people where senescence is going to be a dominant mechanism, as opposed to any one of those other 12 mechanisms. Because again, as I mentioned, aging is heterogeneous. Each of us probably have a different combination of factors that are leading us to age, and in some senescence may be dominant and in others not. So genetic profiling may really help with that. And I think the added complexity was a recent paper showing that within an individual, different organs seem to be aging differently. And so there's yet another complexity there that, there's no simple answer necessarily to aging.
Are there any immunosenescent biomarkers that can substitute for P16 that can identify at-risk persons?
Yeah, that's a good question. So let me just kind of backtrack. And, Dr. Sharpless discovered this T cell expression of P16 as correlating with age and, other factors that might be associated with senescence. We found a variant of that assay, which we modified to be useful as a predictor. I think the question of whether these T cells that are expressing P16 in peripheral blood are themselves senescent or not is unresolved. They may well not be. They may just be activated T cells, for all I know. But they do seem to be activated in response to something going on in the body. So one hypothesis is that, well, if you have a high senescent cell burden, you tend to activate these T cells to express P16, and it turns out to be a useful biomarker for senescence, even though these same T cells are not themselves senescence. So I think, whether it's that or other immunosenescent biomarkers distinct from the SASP, it's possible. I think there is overlap between the SASP and kind of inflammaging, although there are some factors that are more associated with the SASP and others that are more associated with inflammaging or immune senescence. And I think this whole relationship between immunosenescence and mesenchymal senescence, as I've just described, is not well understood. And I think it's been a source of some confusion because when the immunologists talk about immunosenescence, they're talking about a very different phenomenon than the mesenchymal cell senescence that, that we're referring to.
As a cardiologist who's interested in aging in the heart, can you imagine how would we look for senescence cells in the heart? Can you imagine an imaging study which could perhaps help us sort of an infusion with images, or how would you determine the number of senescent cells in the heart?
Yeah, that's a good question. There's a group at Stanford that's trying to develop in humans imaging strategies for senescent cells. And they basically use an assay that is kind of a luminescent SA beta gal assay. Well, yeah. So I can't remember if it's luminescence in the humans or it's some other emitter that they can measure. So they've been able to do that in humans looking at cartilage. So I can well imagine some variation of that is used in other structures, such as cardiomyocytes, to see if it lights up. So I think that's probably the direction, some kind of emitter that's tagged to, a SA beta gal assay. People have described UPAR as a molecule on the cell surface that seems to be highly expressed on senescent cells. So some kind of tag to a UPAR antibody that you specifically image the heart or other tissues. So that would probably be the future direction for that.
Fantastic. Are there any other questions in the audience? Otherwise, we are coming up on the hour. Fantastic. Thank you very much for this fascinating lecture. And I hope to have you back in a couple of years so you can show us the sort of the reverse aging process. I really like that slide as an optimist. That slide that shows us going back from aging to health. So hopefully you can continue to expand on that in the next couple of years. Thank you very much. Thanks everyone for participating in today's Grand Rounds. I wish everyone a great afternoon.